Okay, good morning, everyone, and welcome once again. Today, we're starting off with first aid, and we're going to look at our role as a first aid provider. Now, as I indicated earlier today, still not fully recovered from the flu, and sometimes I have one or two bouts of coughing, so I'll ask that you excuse me for that. Okay, but for now, what I'd like for you guys to do is unmute your mics and let me just stop the share here for a sec. And I'll be back and forth between sharing and stopping the share, right? So what I'd like for you guys to do is, in your own words, right? In your own words, tell me what you think first aid is, right? So go ahead.
So I would say that's the first sort of help you give to someone.
Okay, I
That's
lost you there a bit. I don't know if it's on my end, but you could go ahead again, please.
okay. Hear me clearly now?
Yeah, I hear you a little better now.
Okay. So my interpretation of first aid is the first care or help someone would receive if they have an injury of some sort.
Uh-huh.
So
Okay,
they
all right.
can
Okay, cool. I'll take that. Thank you. Abigail, I saw you had your hand up as well. So thank you, Brandon.
Yes, so I was gonna say something similar to Brandon. I
Which
was just
is?
thinking, it's the care that you give to somebody at the first time that you see that they have an injury or are struggling to do something that they have, like if they have trouble doing something, you would give them first aid, or it's something like if somebody um is, for example, they get a burn, the first thing that you might do is tell them run their hand under cold water. So it's like the first sight of the first help that you give to somebody before they get professional medical help.
Okay. All right. I'll take that, all of that. Somebody else? Anybody else want to contribute? And we have a EMT inside here, Miss Point 14. Right?
Yes, so
Great.
to give the answer,
And nothing. I want to hear what you're saying too.
first aid is the first help that
All
you
right. So
give
so
to
let me
someone.
stop you. Let me stop you for a sec, right? If you let me see what I'll about here. First aid acts as first response in case. All right. Ali, I feel you look like you went in and Google that, girl. I feel like you went online and you get that. But that's okay. I accept that. I'll take that. And again, I have no problem with you guys whilst class is going on. If you're on your phone, your tablet, or on your laptop, wherever it is, you go online and you research to get some answers. This is how we learn, right? If you're not sure, say you're not sure. Nothing is wrong with that. If you want to go quickly and do some research and get an answer, I encourage those things, right? So yes, I'm gonna ask you a question, Miss Point 14. Right. It's Kimberly, right?
Yes, sir.
Right, good. So, right, you're the hot mouth one and Katiana just works in the pharmacy, right? And you say you're the hot mouth one?
Only to that manager.
Only to that manager. Right, okay, good. So, right, excuse me. Yeah, so, um, you like doubles? Aloo pies and those things?
Alupais, yes,
You
sir.
like aloo pies. So if you go by the guy selling doubles and aloo pie, right? And the person before you say, I want, two pies, slight pepper, whatever, if you like sweet sauce and all those things, right? And you order the same thing. When you reach up, it's your turn to order now. What you gonna tell the person? The guy who making the doubles, the aloo pies. You're
I
gonna tell him
want,
your order, eh?
yes.
You're gonna tell him I want what she order.
No, no.
Right? So it's the same thing. The other two, they had a contribution, and even if your contribution is the same thing, I still want to hear it. You might have some subtle differences, and these things may be parts of it that the others may have missed. So each of us, our contribution is important, right? So that's all I'll say. So thank you. Um Aliasa. Oh yes, hey, I understand. Yes, Alia, that the internet across there in South Campus. I don't know if it's because of the number of persons using well on the network, but yeah, so I was there Tuesday and it was fluctuating a bit. Okay. All right. Anybody else want to venture uh their opinion on what is first aid or what you think it is?
I think the others covered the
You think the others
response.
covered it? Okay. So
Yeah.
in a nutshell, first aid is immediate care, as the name implies, first before everything else, aid, help or care, right? So we're looking at immediate care and stabilization. Immediate care and stabilization. Four words. Okay. One of the things we have to understand is we 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 don't try to overcomplicate things in first aid. Okay, we try to keep it simple, figure out what is going on, what needs to be done, and we manage our patients. Now, that said, I want you all to understand as well. First, a lot of people do first aid training because of it being work related. Some people it's because they just want to learn first aid. But we must take into account that we do not diagnose. All EMS programs, starting at the base, the foundation, whether it is first aid, or basic life support for healthcare providers, whatever it is, we follow something called an assessment-based care model. And you'll see it in the PowerPoint, it's called Find It, Fix It. Okay? Just show your hands here. How many of you have your own motor vehicle? Just raise your hands. One. Okay. Anybody has access to a motor vehicle? Your parents, your spouse, your significant other, right? Well, a few of us. Okay. So anybody here has a cell phone? Yeah, I think that might be the easier one. Raise your hands. Cell phone. Raise your hands. All right. Okay. All right. So quite a bit of us, right? Now, why I ask you about the cell phone and the vehicles and stuff? Okay. If you're, yeah, guys, I apologize for that. They continued talking. Eventually, I'm gonna start to cough more and more, right? Right. So let's use the cell phone. We could incorporate the vehicle as well. If you needed to make a call and you dial the person's number, they answered. You are hearing them, but they're not hearing you. The first thing I probably think is the network. So you might tell the person, let me call you back. And if you try again, and the same thing happens, and maybe a few more times, you try different persons, there might be a possibility something is wrong with your phone, right? And you're not just gonna dig into it immediately. You might, if you're not inclined to or don't know how to repair it, like most of us, we might take it to somebody who could check it, right? Literally, do an assessment of it, figure out what is wrong with it, and tell us, and then let us know what the cost is, and then we may have to either make a decision to repair or if to buy a new phone. It depends on if you're on contract and all those things, right? Same thing with your motor vehicle. You're driving down the road and all of a sudden you hear this weird noise coming from the engine. You might not be a mechanic, as most of us are not. So the only way to figure it out is to carry them to the mechanic. And what is the mechanic gonna do? He's gonna do an assessment. It might be using what we call a scan tool to diagnose to see what shows up on the ECU. It might be just asking you to start and let the engine run, let him hear it, or you may have to drive it. But an assessment is done. And it's the same concept we apply to emergency care, to first aid, and all these programs. We assess, find out what is wrong, and then we attempt to fix it, staying within the boundaries of what we were trained to do. And that's all there is to it. It's very, very simple. Okay. So let's let me get the share back up and running here. Guys, I'm gonna continuously apologize for coughing. It's just that this flu really threw me down bad, and to I haven't fully recovered as yet. Okay, so let's go down. So part of first aid involves understanding injuries and illnesses, right? And what you're seeing on the screen here is called the injury pyramid. Now, unlike what we may have been accustomed to seeing on TV and all those things where you see these situations where something happened to somebody and then suddenly CPR is performed and the person miraculously makes a recovery or even a full recovery. That is not always the case, and that's a lot of dramatization, mainly for what we call entertainment purposes. Okay, and to satisfy our minds and the need for a successful conclusion to whatever was the scenario to make us feel good, make us feel happy and comforted. But in real life, typically illnesses and injuries, a lot of them don't really result in death, but we may have other areas and that these situations can be categorized into. So you're looking at the triangle here. At the bottom of it, you'll see injuries treated by first aid providers. We're looking at typically in the workplace or even in the general public, the majority of conditions would be those treated by first aid providers. We're talking about the minor bruise, the minor cuts, scrapes, minor lacerations, those things that you can actively manage and the person does not need to take it any further. Yeah, guys, I'm really, really sorry if it's disturbing you. I apologize for that, right? And the first aid provider in this situation provides the care and it is sufficient. No further care is warranted. However, some of them, not the same amount, but might be definitely would be fewer, but they become more serious and they may require treatment at we see here, emergency department or the physician's office. So here in Trinidad and Tobago, our emergency department is actually called the accident and emergency or the casualty department. Okay. In other parts of the world, such as the United States, Canada, and so forth, you may actually see it being called the ER, the emergency room, or the ED, emergency department. Um, it is the same thing. It's just a name difference, right? It is the point where patients' first contact with the hospital setting occurs. It is not the patient's first, usually, it is not the patient's first contact with healthcare because sometimes the first either may, in this case, the first either may start to provide care and care may be transferred to the EMTs or first responders and then EMTs. It all depends on who responds and how the system was activated. Okay, but more serious injuries may result in the patient seeking treatment at these emergency departments or A&Es, accident and emergency, or even the physician's office, because some patients may not want to go to the public system to get treatment. They may prefer a private physician or depending on the location or the place where the first aid situation occurs, for example, at work, the employer may have an agreement in place with a particular physician or a particular private institution, and the patient is transferred to that location as opposed to the public system. So it's a lot of variables in there, but the more serious conditions are treated at a facility, whether it is emergency department, physician's office, private facility, whatever it is, there is a setting where the patient gets transported to. And then we have a smaller number, their condition is so serious that it actually requires hospitalization. So what I'd like for you guys to do is just give me about two or three conditions where patients, once they enter into the hospital, the accident and emergency department, some conditions where they may actually require hospitalization to properly manage and treat their condition. So give me a couple of those. Let me hear you.
Asthma is one.
Asthma, definitely. Good. Anything else? Somebody else?
Burns.
Burns, yep. And again, it all depends on how severe the burn is and how much surface area, right? Because sometimes, let's use a first degree burn like a sunburn. It might simply be just go and the physician assess and they may prescribe something. But if we're dealing with second degree and third degree burns, they may actually require um, being admitted to a ward and you have in-hospital treatment. Right. What else? Somebody else.
Like myself, seizures.
Seizures, okay, yeah. And usually, um, it's more of having you kept for observation for a period of time, and of course, having that assessment by the physician to determine what is the situation, what would have triggered, what may possibly have triggered it. Um, your medication, it may be your medication needs to be changed, or this dosage needs to be changed or adjusted accordingly, right? But that level of interaction is required with the physician, and of course, to keep you for observation for a little bit. Right. What else? Is somebody? Yes, Abigail.
So like if you fall down and you break your arm or leg, or you get a fracture, or like your lower back is paralyzed or part of
Right.
your body.
Okay. So we have musculoskeletal injuries, and typically with the musculoskeletal injuries, such as a fracture and stuff, it depending on, and yes, depending on where and how severe, because sometimes if it's the limbs, the arms and the legs, it might very simply be get in the system, get into orthopedics, have the necessary X-ray assessment and X-rays done, and then the physician may chart the course. Sometimes it might simply be to put a cast and put it in a sling, or might just be to reset it, or simply do an anatomical splint. For example, if it's a finger that's fractured, just bandage onto the adjacent finger. In the case of possible paralysis, may have been from a fall, a motor vehicle accident and stuff. Definitely, it may require hospitalization. Some cases, hmm, excuse me, may require surgery, right? But yeah, I saw on the chat here earlier would have indicated chest pains if they have a known medical condition like high blood pressure. And actually, I was quite surprised that nobody spoke on, nobody mentioned a possible or suspected heart attack. And these would normally just one sec, Miss Jordan. These are normally the ones that definitely is sure. You get into hospital and you have chest pains. They want to do a ECG. They want you to see a cardiologist and so forth.
So what hospital is that?
Huh?
What hospital is that?
Let me ask.
Because no, I think like with chest pains and stuff, you don't get through right away. So it have to have some other indicators upon
Right.
entering that would
So,
scare.
from all the interactions I've done with the hospital system, on normally when you get in, whether you come in with an ambulance or you come in on foot or somebody brings you there, normally the interaction is you go to the triage nurse who does the screening. And here in Trinidad, Tobago, we follow the Canadian acuity and triage scale, right? Where you're classified, you're given a number based on the severity of your condition. So like levels 1, 2, 3 would be, well, levels 1 and 2, I think the time to see the doctor is supposed to be, and I say supposed to be, yeah, within 5 minutes to 15 minutes. Level 3 might be 30 minutes, and so you go. It all depends on the seriousness of the condition. But from the years I would have been in the system, and even with some of my instructors now who work full time with the ambulance service, typically normally things like chest pain, asthma attack, suspected stroke, and those things, there's not supposed to be any lengthy wait time to see a physician once you get triaged by the nurse, right? And they give you the requisite triage number. Well, this is how the system is supposed to function. All right. So I know sometimes we have little hiccups in that, but yeah, this is how it's supposed to be. Okay. Any others you guys want to add?
Um,
So
I would.
last question
Yes.
or women, huh?
Let me hear Brandon first. Like that. It's either Brandon or Justin. Right.
Oh, it was me, Sir Justin.
Yes, Justin. Go ahead.
Any things that like causing any kind of like excess bleeding, like Lucy Vincent, you get cut or stabbed or anything like that?
Right. So major bleeds, yes. Then depending on if it's an assault and so forth. Depends on based on the assessment if any organ has been injured or any large areas that may require surgical intervention. Because typically, if it's those situations that require stitches, it might just be to keep you for observation for a little bit. When we're looking at hospitalization, maybe a day, 2 days, 3 days, depending on what's going on with the patient, right? So yeah. Now I just wanna just hold up there for a little bit. The reason why I speak about hospitalization, it is when we're looking at the injury pyramid, the higher up the pyramid you go, the more serious the condition actually is. And you'll realize it's a fewer number of cases. The worst case scenario, and the fewest cases, if you look at the pyramid here, is actually the ones that result in death. And excuse me, these are the ones you would see on your television for entertainment purposes. Suddenly, they do some miraculous intervention and the person regains consciousness, they regain a heartbeat, they're suddenly alive, right? And then they get discharged in a very short period. It does not work that way in real life. So what you see with respect to those things, that's just for entertainment. Okay? But right. But for this program and for us, at the level of first aid, you would have the largest number of cases. And usually these those that are treated by you can be managed properly. However, you have to also be mindful that some of the conditions may be more serious and the stabilization required may be beyond your level of training and what you can do. With that said, you're still not allowed to do things that you were not taught. So, for example, if we're looking at managing a patient with an airway issue, right? We may look at certain things we can do for an unconscious patient to keep the airway clear. So if you've done first aid before, we have our colleague who's an EMT here. We can do things such as, and I'll just mention it, right? A head tilt chin lift, which is basically lifting the chin, tilting the head back to lift the tongue off the base of the airway. And that's one technique to help get a clear or a patent airway. Nowhere in there will Nigel tell you, well, if the airway is compromised or there's an airway blockage, we take a knife and cut the windpipe or the trachea and stick a pen barrel in there to allow the person to breathe. No way. Nigel never taught you that. And that is not a skill that even EMTs and most paramedics are not authorized to practice or to perform. Okay, so I just want to hold up on that there and move on to the next slide. And we'll have some nice discussions as we continue with the situations in the hospital. But I want you to be mindful of the fact and remember that
some of these situations people experience may be challenges to the healthcare system, but we also have to look at what the correct procedures are. In EMS and first aid and stuff, we typically look at what happens in the area called pre-hospital. Hmm. Again, I apologize. Pre-hospital care outside of the hospital. What happens to the patient at their location, what is done, and who is the care transferred to until the patient gets to the hospital. Okay? So the importance of first aid. It is better to know first aid and not need it than to need it and not know it. Somebody explain that. Tell me in your own words why how is this important? Why you think this is important? Um what do we mean by that? And all those things. Just explain that statement to me in your own words. Break it down. It's very simple, right? So just let me know what you're thinking.
So,
Um,
oh, go ahead.
Feel free. No, I not
I
seen you guys, eh? I just have the PowerPoint up here.
So I was going to say a concise statement is better to be than be prepared and fail to be prepared.
Mm-hmm.
In other words,
Mm-hmm.
it's better that you know first aid where you can actually render help to someone than if you don't know it at all, you don't know how to render proper care to them.
Right. So thank you. So let's expand on that. Why is it better to have that knowledge when we're gonna render aid? Somebody else tell me. Why is it better for us, beneficial for the patient to have that knowledge on what to do? Anybody?
I think it's better to know because so you could like accurately carry out the procedures rather than doing it and like not knowing and causing more problems to the patient.
Mm-hmm. Mm-hmm. And that's exactly it. That's it. Right? The knowledge is always beneficial, right? And actually having the information, knowing what to do is better for the patient because if you don't know what to do, you might revert to what you may have heard growing up or what you think might be correct, and that might actually be detrimental to the patient. So you're quite right. Okay. So moving on here now, we have the goals of first aid. And let's look at each one of them. The first one you see here is preserving life. Life, sorry. So somebody I said preserving life. Wow. Preserving life. Um, Somebody tell me, what's the absolute worst thing that can happen to someone? Absolutely the worst thing that can happen to someone.
That
Death. That's it. Exactly. Doesn't matter what the cause, the absolute worst thing that can happen to any one of us, we could die. So when we're looking at first aid and emergency care, we have four main goals we want to accomplish. Hmm. Yeah, so the first goal is to keep the person alive. Whatever we're doing should be geared towards preserving life, keeping the person alive. Now, a lot of times, whatever stabilization we're doing to keep the person alive actually helps to alleviate suffering. It may reduce the pain a bit. It may actually start to put the patient on, all right, on a path to proper stabilization. So yeah, keep the person alive, and by doing that, we actually help to alleviate suffering. And these two tie into the third one, preventing further illness or injury. Now, sometimes, and this is where we have to be absolutely clear with this. Sometimes, in our attempt to stabilize a condition, we may be required to turn the patient or move the patient. And temporarily, they may get an increase in pain. Sometimes they may get the condition, um, may get slightly worse based on their location, what is going on, and they need to move them. But we understand that leaving them in the position or the location may not be in their best interest for recovery, for stabilization, and so forth. So moving them at this point in time actually is part of the first goal, which would tie into the second and actually third, to prevent the condition, to prevent further illness or injury. Sometimes it may not be possible to prevent that further illness or injury in an attempt to stabilize the patient. Unfortunately, but the majority of the times it is possible to stabilize without preventing further injury. Okay? And the easiest way to manage those situations properly is to remember what you were trained to do. And sometimes, well, not sometimes, but a lot of times, if after we've completed one of these programs and we're not keeping our skills current, we're not practicing or doing practical sessions or training sessions, we tend to lose the skill. And that is normal for any one of us. So we have to figure out what are some of the unique ways to keep us current or up to date with our skills and knowledge. And we look at that as we go along in the program. And of course, the fourth goal, whatever you do, should be geared towards helping to promote recovery. Stabilizing the condition you prevent it from getting worse and actually sets the person on the path towards recovery. Sometimes it might be simple as to apply a splint, a sling, a bandage, stop the bleeding, and of course, get further help on the way. Additional healthcare professionals, get them on scene, make the call, or get somebody else to make the call to have these professionals getting on scene to take over care of the patient from you, or you get a healthcare facility with the patient. Okay, so remember that four main goals of first aid: preserve life or keep the person alive, alleviate or reduce suffering, prevent the condition from getting worse, so we're preventing further illness or injury. And of course, by doing that, the fourth goal, we set the person on the path to recovery. So we're actively promoting recovery. Okay, so we must be able to recognize something is wrong with someone. Okay, in order for us to fulfill the role of a first aid provider or the function of a first aider, whether you're at home, whether you are a safety warden or a fire warden at work, that is your responsibility, whatever it is, we need to be able to understand these rules. And it starts with every single thing here, starts with recognizing the emergency. You cannot activate a system without some sort of recognition that something is wrong. Okay? So, how do ambulances get dispatched to a call or to a location? Somebody would have observed whether it is the patient's relatives, whether it's the patient thinking, understand the condition he or she is in, or whether it is a bystander or a passerby or somebody realizing something is wrong and making a phone call. At work, it might be somebody verbally coming to you and saying verbally, hey, something is wrong with this person, so it's a verbal notification. Whatever the means of the notification, it comes in, and then the appropriate response now takes place there. All right. So we always start with being able to recognize emergency, and that is the only way in which the EMS system and first aid care as well gets initiated, being able to recognize the emergency. So on your screen here, you have a couple of little pointers, a couple of little tips here. Factors that help the first aid provider recognize an emergency. So we have some of them, and of course, these are not all. but it's a guide. The severity of the injury or illness, the person clutching their chest, person gasping for breath, person got assaulted and you see they were stabbed or the person was chopped. Um, so you seen a lot of blood on the ground or you see a bleed that's actively spurting or and those are visual and very obvious ones, right? We can also have the ones where the patient is withdrawn, the patient doesn't respond, the patient might be unconscious. Okay. How close you are to the emergency scene and the length of time you are at the emergency scene. Hmm. Okay, the person's distressed appearance or panic stricken. And we know, just by reading that statement in your mind, most likely you would have gotten a mental image of somebody's distressed appearance, somebody looking obviously sick. Okay, a panic-stricken behavior, somebody who, for example, somebody getting chest pain and they start to panic, you see the eyes bulge out, you see this look of fear on the person's face. Somebody getting a panic attack and their fingers start to cramp and they don't know what to do and right, they're just not listening to anybody. And, okay. Previously knowing and recognizing the injured or ill person, you know the condition, the illnesses they suffer with, and it aids in making it easier for you to identify what is going on, and then you can attempt to stabilize them. So you're able to recognize what is wrong with this person. The conditions of the scene or where the patient is located. Let's say there's a burning building, the patient was just pulled from a burning building, so they may suffer from smoke inhalation. Of course, obviously that's an emergency. Okay. With the knowledge that there is an emergency, something is wrong with the patient, we move to the next one, deciding to help. Okay. So I'm just gonna stop the share here, and what I'm gonna do, I am going to mute, and we have one, two, three, four, five, six, seven, eight. Um, Eight of you guys here. As a group, I want you to discuss for 5 minutes, right? Reasons why it is important. Well, two things I want you to discuss. Why it is important to make that decision to help. That's one aspect of it. And I also want you to come up with some reasons why you would not want to help a patient in an emergency. Okay, so we're looking at both ends. Why it's important for us to help, but also why you should not help. So I'm just gonna go mute for 5 minutes. You guys can take over, have your discussions with each other. It's one entire group. Come up with the reasoning, and when I unmute, I'll stop the recording as well, and then I'll hear what your contributions are. Okay? So you guys could go ahead. All right, guys. So let me hear you. Reasons for wanting to help the person.
Natural instinct
Mm-hmm.
is one that we had. You know, when you see someone in distress,
Mm-hmm.
you usually your instinct is to help relieve
Right.
one.
Okay.
And then, to preserve life,
Mm-hmm.
you know, you don't want them to die, so you try to help in any way. And the next one is to reduce, I would say reduce injury or promote injury recovery. You know, if something happens to somebody, you want to help them to start recovery and or help them to reduce pain
Right. So to
until
set
they
them on
can
your
get.
road of full recovery faster, right? Good. So there's one aspect of it there. Anything else, or are you okay with that? Anything else, or we all agree with the points um that was said just now?
So we all agree. One person was just taking notes.
Good. Nice. So there's one other thing, in terms of wanting to help or making that decision to help, right? We have to look at, is it your role and your function in this part of your job responsibility, or as we say, a duty to act, which we'll discuss later on, but is it that your job requires you to make that decision to want to help? Okay. In the case of safety wardens or fire wardens, as the case, once you have accept that role and responsibility, it's expected that if there's a patient or someone requiring help at the location where you have a responsibility for, then you are required to provide assistance. Okay, if you're being paid to function in that role, you have a duty to act. You're required to provide care. Okay? All right, so the other side now, why would we not want to render aid? Safety comes first, you don't have knowledge. Okay. All right, thank you, Abigail. Anything else? Anybody who's the spokesperson for this one?
Well, surprisingly, we had a little more.
Go ahead.
Should not done. Should. Was risk of infection, risk of catching an infection if the person has a disease such as COVID, anything like that.
Okay, you're breaking up really bad on me there.
Um,
I heard risk of infection and the disease such as COVID, and then yeah, so we
if
get
there's a
it.
professional on site. I said professional on site. If there's an injury and a professional comes on site, I think it's best for you to just step back and let them do their thing. We have the matter of consent, which can go with religious beliefs. Some religions don't believe, like Jehovah Witness, don't believe in the sharing of blood.
Right.
And then you have the matter of some people have, as one of the team members say, a DNR on them, which means you're not supposed to, render
Good.
any type of CPR and
Right. Excellent. Excellent. So
like
yes,
that.
yeah. Right. Anything else you want to add to it? Risk of
But
disease. Mhm. I just reading
and then you
what
have
some of the
danger
other
to
persons
yourself
put on
and
the chat as
others.
well, right? So yeah.
Okay.
Yeah. So you continue.
We have lack of training. You might not know exactly how to perform medical training, so it can cause more harm than injury. More harm than, help to whoever is in need of it. And then you have danger to yourself and others. One of the examples was in the case of a shooting. You cannot run to the aid of somebody if they're still an active shooter. You have to, ensure it's safe for both yourself and the injured. And I
Okay.
think that's it.
Nice. With all of these, guys, that's excellent work. I mean, I commend you guys. That's excellent work. I'm sure somewhere along the line, well, I would hope that the personnels in the hospital setting and the personnel would have done first aid training, the EMT training. You guys would have had an input in this as well, right? Um, Definitely all of those. So what I'll tell you though is in case of situations where you have oh gosh, just give me 1 sec with this, eh? Um
Yeah, the pressure on your side right now. You see, I'm like, I
you
know
feel you
about
get
this.
set up?
Listen, I banked on you to carry this class right now. Right now.
Uh, so I'll tell you something, right? Um I would have never said I did an EMT program. Honestly,
Likewise.
I would have never say that. You shoot yourself in your foot there. No, but it's all well and good, and I'll tell you why I appreciate the honesty because this is just first aid as part of the curriculum, and your input
especially for the person. I'll use one of the young ladies here as an example who has no training. You have an opportunity to help her understand what are some of the things that she needs to do. All right. I am here to facilitate the knowledge being imparted onto you guys. But outside of the class, there are other ways we could get information across, which brings me to one part of it. I'll just pause the recording here for this, right? Coming back, yeah, so coming back to why we shouldn't we or why we would not want to help someone, and let's look at having another healthcare professional on scene. This person is higher trained. We don't want to take over the scene. We could offer to assist, right? If you wish. But once there's a higher trained individual on scene, that person usually has control of the scene. It's not mandatory. You could step back if you wish. Um, Sometimes, depending on the number of patients or on the seriousness, sometimes one person alone may not be able to stabilize. And if you're able to, you could try to render it if nobody gonna force you if it's not mandatory. It's a purely your choice, right? And thinking about it, we look at it, if we look at occupational health and safety, it's thinking about a moral obligation or for the greater good or wanting to help your fellow man. Okay? Of course, definitely the possibility of infection, lack of proper equipment, all those things are valid reasons for shying away because, I mean, we were concerned about the possibility, and I like the fact that you use COVID because this is the most common one in everybody's mind based on the pandemic that we all, excuse the pandemic that we all lived through. Okay, so yeah, um, that said. One of the things I would advise you to do if you want to render aid and you don't have the necessary equipment or tools, try to identify what you may need, try to identify if there are unique ways of helping without getting yourself in the pathway of becoming potentially infected. Sometimes you actually have to step back for a couple of minutes and actually think about it and figure out what you're going to do to help this person without exposing yourself to the possibility of infection and all these things. Okay? All right. I think we okay with that. Everybody clear on that? Anybody has any questions, queries, concerns, um, comments, observations, anything of that sort? Or can we move ahead?
We can move ahead, sir.
So let me get back up the PowerPoint here. And so a lot of people would have reasons why they want to help, as we would have just discussed, but also we have reasons why people don't want to help, and each are all valid. What I would advise you though is please don't don't put yourself in a position where you are required to provide care and you end up shying away from it. Because then, especially at work, you open yourself up to a whole set of actions for that refusal of not wanting of for that refusal of let me see how to phrase it properly. For that refusal to provide care for the patient. Yeah, I think that's the simplest way I could describe it. Okay. As when we talk about that, we were looking at that duty to act, that mandatory requirement for you to provide care. And if you shy away from that, you open yourself up to disciplinary action and all those things from your employer. And we don't want to be going on that road. Okay. Now, we've looked at all those things. We understand what's expected of us, reasons for wanting to help, reasons for not wanting to help, all those things. But we also want to look at we've decided to help. What do we do? Do we just run in? No, we don't. Okay. So I'm gonna give you an example here of a situation. I'm just double check again. I'm gonna give you an example of a situation. Right, so whoever created the group, can you just add me? Can you just go ahead and add me to it, please? Thank you.
Um,
Right,
Hi, sir. I added you and I sent the link to join for others to join the WhatsApp group in the Zoom chat.
nice. So thank you very much. All right, guys. So yes, let me give you a scenario here. This is an actual situation, a call that I went on. All right, and I'm not gonna use people's names because I'm not gonna remember people's names. I'm not gonna give you the exact location. I'll use the general area. So for all of us, and for my Caribbean colleagues, I was working on the ambulance as an EMT at that point in time, and we were dispatched to a call in South Trinidad, right? And the call, the information we got was basically unknown situation. Somebody called, requested the ambulance, and before any further information, the call dropped. Okay, so they gave us the general location, and we proceeded there. Upon entering the street where we were told the patient was supposed to be somewhere around there, we saw a crowd of people, right? Fair bit of people. What it looked like is the neighbors and everyone around came out, and people were in the road, right? So we drove up a little bit, and then we stopped. Typically, in unknown situations, we do what we call staging, which is you park or you stop at a safe location where if there's a situation that requires you to exit, you could exit safely and quickly, so no harm comes to you and the company's equipment and ambulance and those things. So we are staging, observing the scene, trying to figure out what's going on. And two um two guys ran up to the ambulance and they told us EHS, well, our service at the time was called EHS, Emergency Health Service of Trinidad. Now it's GMRTT. So they said, EHS, the man inside the yard there. So I was like, okay, tell me what's going on. Because we don't know. All we got is there's a call here, tell us what's going on. And I kid you not. So I'm gonna say that, and I'm not gonna be offensive. I'm just gonna tell you what the guy told us. One guy came home, caught another guy with his wife, and he proceeded to chop him, to assault him, to chop him. All right? I am going to pause with the story right here. And let's discuss now this whole section of, let me actually share it back here. This whole section of before helping, we take appropriate actions, and we have this one. Size up the scene. Now, sizing up the scene means you are observing the area, the location of the patient, in an attempt to identify things like how many patients there are, what you think is wrong with the patient, do you need additional help, what dangers are there. Okay? So tell me, um, what do you think you would believe is going on with that scene? What are some of the things you would believe is dangerous to you? What information you think you might encounter or identify when sizing up the scene?
So I will first ask if police was called and if police was on the scene.
Right. So in our situation, police was not on the scene. We relayed the information back to our comm center and they contacted the police after we got that information from the bystanders. Right? So that's the best I could tell you. They were not on scene as yet.
Then I will ask if the person who's attacking, if they're still in the area or if it's
Still in
still
the area, in the yard, probably about 10 feet away from the patient who was chopped.
I might wait until the scene de-escalate and wait until police arrive before I go to render aid, because I don't know if he's still hot and still, swinging the cutlass or whatever it is.
Good. Good. So now this means there's the potential for you to be injured, for you to be attacked, right?
Yes, sir.
Good. Anything else you want to add to that?
For now, no.
Anybody else?
I would agree with Kimberly because yes, you would like to, yes, you're there for the safe, to help the other person who got shot, but at the same time, you also have to look out for your safety and well-being.
Right. That's right. So the biggest danger there is your safety. Well, the biggest issue here, I won't say danger, so the biggest issue is your safety. And the fact that the patient and the alleged assailant at the same location, there's increased risk to you. So these are some of the things we look at in terms of sizing of the scene. We look at what dangers there are. We look at the patient having been chopped, the exposure to blood. If you may not have all the necessary tools, we look at the crowd. The crowd might be nice and calm now, but when they see nobody helping, and you know the first, you decide to go and help, and in their minds you're taking too long, and all these things, right? So yes, definitely, we have a lot of situations in this, and the reason why I chose this scene is because I want to highlight to you the importance of ensuring your safety. So just to finish the story with us, and you're all correct, right? Just to finish the story with us, um, we contacted our comm center, our dispatch center. They contacted the police. The police got there literally within 5 minutes because the station is actually 5 minutes from the police and from the patient's location. So they got there. We waited until they arrested the alleged assailant, and then we proceeded to provide care for the patient. Okay? The sad part, actually, I'll just pause the recording here. So back to sizing up the scene. We have to take into consideration the patient's location. Yes, definitely potential for infection, what equipment we have or we don't have, how far away emergency services are, um, if we need additional help, and all these things. So we have enough information about the situation and the patient. Okay. Obviously, when we get to the patient, once the patient is conscious, we ask if we could provide care. This is called getting consent. Okay. So the conscious patient, we ask, can I help you? And every single patient I have attended to as an EMT from 1999 come all the way up to 2025. Good day, sir. Good day, ma'am. Or good day, uncle. Good day, auntie. Pops, how you going? My name is Nigel. I'm an EMT. Can I help you? That's it. Yes or no. I've had majority of patients say yes. I've had push excuse me, I've had patients tell me no. And of course I do step back, I try to convince, but I don't force care onto somebody. Okay? Always remember to protect yourself against disease transmission. So at work, if you have a first aid kit, get your first aid kit while sending it to your patient. As a minimum, you should be wearing a pair of gloves. Okay? Depending on the situation, you may want to consider wearing a mask. If there's a lot of bleeding, you may want to consider wearing a goggles or safety glasses. If you're employed by a service, they may tell you universal precautions required. It means you need to implement all the necessary PPE or BSI, body substance isolation, that you may have. So in emergency care, in healthcare on the whole, you will hear BSI, body substance isolation. It is actually PPE, personal protective equipment, and is designed as just as everything else to provide protection, one, prevent you from contaminating or infecting the patient, and prevent the patient from contaminating or infecting you. So it goes that protection across both ways. Okay? Figure out, observe, and figure out what you need to help protect you from disease transmission. Okay? Any questions?
No, sir.
Okay. So, in terms of determining what's wrong with the patient, remember I said earlier we use an assessment-based care model, right? And this is very simply called find it, fix it. Find out what is going on, what is wrong with the patient, and you attempt to fix it within the boundaries of what you were trained to do. But what do we do for the person who has no training? The lay person. This person has no idea what the recommended treatment measure, recommended techniques, and all these things are. All right. So what do we do? Anybody, I'm open to suggestions. What do you think we can do? Anybody?
So offer advice,
Mm-hmm.
offer advice to the person who
All right.
don't know.
Okay, so let me just rephrase it. We are actually not on scene. So we're in class here and we are trying to figure out what do we think somebody who I think I maybe ask you guys it or phrase it incorrectly, and I apologize for that. What do you think we can have someone who is not trained, what we can have this person do to ensure proper care or proper aid is rendered to the patient? What can we do? Suggestions. What do you think we could ask the person to do? We are not on scene. The trained person is not on scene giving advice. We're not on the phone giving advice. But what do you think they could do to ensure that proper care gets to the patient? Anybody? Let me hear. So with that, let me hear what you think we could or they could do.
Well, I would say based on what they observe happening to the patient, they could like, I guess, Google and see like what's like the basic or not necessarily the
Right.
basic,
So they
but
could
what
do
they
some
can do
quick
to help
research.
aid. Yeah.
They could do some quick research, right? Okay, I'll take that. But there's something even easier than that.
So they can call the ambulance.
Right, and that's it. As the simplest, easiest thing they could do. Call for help. Call the ambulance. So here in Trinidad, what's the number for the ambulance in Trinidad and Tobago?
811, I believe.
811. Good. Um, Let me hear my colleague in Antigua. How do we access the ambulance service in Antigua, the emergency services?
Excuse me?
How do we access the ambulance services in Antigua? What's the number we call? Is it a three-digit number? Is it a different number? What?
Well, we just usually dial not just to the line or they will send dispatch.
What's the number you dial?
911.
911. Good. Grenada. Our colleague in Grenada, what's the number we call for the ambulance services across there? Hello? You guys hearing me, right?
Fraser, he talking to you.
He talking to me?
No, I'm telling Fraser.
Oh,
He's
okay.
from Grenada.
Yes, Mr. Fraser. What's the number we call in Grenada to get the ambulance?
So, can you hear me?
Yes, I'm hearing you now.
Right, I was tapping the mic icon, but for some reason, again,
Yeah. So
911.
I'm asking you, if I need to access the ambulance in Grenada, what's the number I call?
We call 911 as usual. Or if
Okay.
you know the direct line to the hospital, you
Right.
call.
Right. So 911 is typical. Thank you. So 911 is typically the universal thing in the western part of the world and stuff, right? In some countries, it actually may have 112, right? And if you look in, I think some parts of Europe, it might be 112. I'm not sure what it's in Australia and stuff, but it's usually some some three-digit number, right? In Trinidad and Tobago, if you call 911, I believe it is supposed to be that call is supposed to be routed to the police command center, the 999 number, and I believe they're supposed to be able to connect you with the ambulance service. But to access the ambulance service directly, it is 811. And that decision, just hold one sec there, Kimberly. That decision making is way above my pay grade. That is the upper level personnel executives making that decision with the 811 and 999 and 990 numbers and stuff. Yes, Kimberly, you could go ahead now.
So Grenada ambulance service is 434. I just Googled.
434?
Yeah, I
Okay,
just Googled it.
right. Okay. Um, and we heard Brandon tell us that 911 works as well, right?
That's police. Yeah, that's
Right.
police.
So, um, whichever it gets you to the ambulance service, that's the number you want to use. So it's the same thing here in Trinidad. 911 is routed to the 999 command center, and they could transfer you. Okay? So one of the things I want to make clear as well, what you see on TV in the United States, where you get an ambulance, you get a fire truck, you get a police unit, dispatch, it does not work that way here in Trinidad, and I'm not sure for the rest of the Caribbean. You call 811, you need an ambulance, the ambulance comes based on the order, the calls come in, and the severity of the condition and those things, right? We all know we have a challenge in terms of the speed the ambulance gets to your location. If there's need for additional resources, well, then they'll make those necessary arrangements and stuff. But what we can do in the interim, whilst waiting on the arrival of the further help, we can very quickly do an assessment of the patient, find out what's wrong, and attempt to care based on the boundaries of our training. So most cases involve just checking the patient's chief complaint, asking them what's wrong, and they tell you, and then you attempt to stabilize. But in some cases, and that would be if we go back um to this pyramid here, asking them what's wrong, and they tell you and you're able to stabilize it, that's the bottom of the pyramid here. Injuries treated by first aiders. Okay? But there may be some cases where we have to do more. So when we're providing care, when we're giving first aid, okay, we give first aid until one of these happen. EMS and the professionals arrive and take over. We get the facility, or all we needed to do was provide first aid and home care and the patient is okay. One of those three things happen. What we do not want to do is start to provide care and just drop the patient in the middle of providing care. We don't want to do that. That's issues, that's problems. So how do we look at what do we consider in terms of the competencies required for giving first aid? We have some of them listed here. It is important for us as first aiders to be able to recognize, assess, and prioritize the need for first aid. So I'll tell you now, obviously we recognize there's an emergency, the patient needs care. In terms of assessing and prioritizing the need for first aid, we always look at who has the most serious condition. That person gets treated first. Not who is screaming the loudest. And typically, well, from with all the years on the units I have, the one who's screaming at the loudest I am happy because it tells me the person airway is clear, they're breathing, the brain is functioning, right? So the spinal cord is intact, all these things. And this person is thinking by screaming the loudest, I will get care first. But when we look at the emergency situation, we're looking at what is essential for life. Airway, breathing, circulation, a clear airway, so you have air entry and exit. Breathing, you need to be able to breathe to be screaming at that loud. And of course, see circulation, your heart must be beating to pump blood to have you at that energy level. Right? What we're going to look at is the guy who quiet, who not responding. Provide care using appropriate knowledge, skills, and behaviors. What we learn, what you will learn, what you were taught, and what you've learned in your classroom. But we also must understand there are limitations to our training, to what we can do, and seek additional care when needed. So I would tell you, how do we ensure that we're able to provide care, provide what may be the correct care, and ensure help is on the way? We call for help. And call for help assists with a whole lot of other areas as well. Okay. So you're a first aider, you did a first aid program. You come across a situation where there's somebody needing help. You're in two minds because you're not sure if what you're doing might be correct. Easiest way to rectify that, you call the emergency services. So in Trinidad, you call 811. And 811 gets you to a trained dispatcher who will be able to give you instructions on what to do to stabilize the patient until the ambulance gets there. This is a universally accepted method for helping to stabilize and manage a patient until the ambulance gets there. And you know what's the nice part of that? You are now taking instructions from a higher trained individual. Okay? So it helps to reduce a lot of the liability for you. You are no longer functioning on your own. You are functioning under the instruction of a higher trained individual who has excuse me, who has the appropriate level of medical legal coverage. This person is authorized by a physician with the appropriate license and all that sort of stuff. So this person is covered to give you instructions. That is a universally accepted method and process. Okay? Always remember there are limitations to what we can do based on the level of training and where we are. And the sad thing about that is sometimes patients may not survive because we could not do more for them. That's just how it is, unfortunately. It's sad, but that is the reality. Some patients may not survive because they may be needed to be in surgery, in theater within 10 minutes, but you are half an hour away from the hospital. Some patients may have needed stabilization in 5 minutes, but your training would not allow you to do the appropriate level of stabilization required. A lot of times that has happened with us on the ambulances, and that is just unfortunate. That is the part and parcel of it. It's sad. Okay, so I don't know if any of you would have seen recently the most um are coming out of the United States, where this guy Charlie Kirk was shot right in the neck. And even with the most advanced trauma team on site, the level of damage to the neck muscles and the neck veins, the blood vessels in the neck, and all that, it is highly unlikely that he would have survived. I mean, yes, he passed away, and I'm drawing that to your attention, not on the premise of whatever his messages were. I am drawing that to you on the premise of for you to understand that even with the most advanced trauma team, if they were actually on site, unfortunately, in some cases, the patient's condition may be so severe that they just may not survive. people will die. That is normal. That is what we try to do within the boundaries of our training is give them a chance for survival. But again, we need to stay within our scope, within our standard of care. Okay? All right, so we would have discussed these things here. Um, Looking at the helping attitude when we decide to help, it is beneficial for us to understand the importance of helping the patient. Okay? Practicing and performing our skill helps with confidence, even if we have other people. And most of the time, you'll have other people on site, bystanders, and you can utilize them. Be willing to take time to help. And I'll tell you something, once you make that decision to provide care, you need to see it through. Either you're with the patient until they get to the hospital, or stay there until the ambulance comes, or another first aider or somebody with a higher level of training comes and takes over. That's okay. But once you make that decision to help, you cannot just drop the person in the middle of care and you bust out. Okay? Be able to put the potential risk of helping in perspective. Understand that there's always risks. There are risks associated with you providing care in terms of infection, in terms of injury, and all these things. Okay? And that is why we do this scene survey. We observe, we assess the scene, figure out what is going on, so we can make what we call an informed decision. Feel comfortable about taking charge if needed at an emergency scene. And usually, if you are a very reserved or very quiet person, this is one of the most difficult parts of it, having to take charge at an emergency scene. A lot of us tend to shy away. But what I'll tell you is you have to look at that together and match it against, if I don't help this person, what happens? Okay? And we normally tell you, think about if this was a relative of yours, what would you do? Would you step back or would you go forward to attempt to provide care? Feel comfortable about seeing a person who is bleeding or vomiting or who appears dead. I'll tell you something with that. I have a colleague who is a rescue professional, okay? And with a lot of the companies in Trinidad and the doing work in the Point Lisas industrial estate and Pointe-à-Pierre, in the oil and gas sector, even offshore, he's done a lot of work as part of rescue teams. Okay. And for whatever reason, he just cannot see blood. Starts to feel all woozy and dizzy and all that sort of stuff to the point he actually has to lie down. There was one patient I went for. He was actually on top on a tree, cutting some branches, and he nicked himself. And when I say nick, he literally got a little scrape. So if you were to take one of your fingers and scrape, literally make a line with the fingernail onto your other hand, your next hand, that little line, if it's deep enough, you might end up getting probably about a millimeter wide, less than that. And you might see a little, all right, so it's just like if you get a scrape and you see that little red line formed. No major bleed, just that little red line formed. He saw that and he fainted and fell off the tree. That some of us are just like that. Just as with some people who cannot be in confined spaces, just like some people who are afraid of heights, that is normal. What we could do is try to figure out what we can do to, or what is recommended so we don't get exposed to this situation, to the blood, to the body fluids, to the elevated area, and those things. And sometimes it might be telling somebody else what to do. You cannot look away because you actively have to look if it's a situation to control a bleed. Okay? So we just have to assess each situation and find unique ways to manage our patients. Okay? Right. Provide comfort and reassurance to the person you are helping. And usually the idea with this is all about building a rapport with the person. And as you continue to talk to them, you get them to calm down. Psychologically, that level of reassurance helps to manage their vitals and usually can help to lower a racing heartbeat, elevated respiratory rate, all those things, right? The idea is to keep talking to them, get them to understand what you're here to do, get them to be comfortable with you, and you start to calm them down. And as they calm down, it assists immensely with managing the emergency situation. Now, I talking all nice and cool with this, but I'll tell you, it is easier said than done. It requires you to make that effort. And one of the things you do not want to do is give the patient the impression that you know something um, very bad is going to happen to them. Or you don't want them to think that you just don't care. Make an effort to get the patient comfortable with you. Build that level of rapport. And I'll tell you what helps us is as people from the Caribbean, we are, whether we admit it or not, we are a very friendly bunch of people. And that works in our favor because we could go to another country and call somebody uncle or auntie or pops or moms or whatever it is, and they might respond. Or they will respond depending on where you want. And that itself aids in building a rapport with the person. It aids immensely. Okay? We have some guidelines here for establishing a relationship with the person. Okay, that we're treating. Username. If you don't, um, some persons prefer to call them sir or ma'am. You can ask, nothing is either yes or no. Can I call you uncle or auntie or what's your name? And you refer to them. For me, I've been in the field so long, anybody has uncle, auntie, moms, pops, that stuff, and I okay with that. And it has never failed me as yet. And that's why I keep saying in the Caribbean, we are so friendly and comfortable with each other. That is not a problem. Okay? Your first words to the patient are very important because it sets the tone, right? And if you come across in an aggressive manner, the patient may shy away from you. But if you come across in a friendly, calm manner, it helps reduce that level of anxiety. And this is what we want to do, reduce the anxiety level with the patient. Avoid negative statements that could add to the person's distress. So you're not going to take a phone call and tell you whoever on the next line, yeah, I have a little patient there, I stopped to help somebody, but I ain't feeling gonna make it and he ain't looking too good. But I could be wrong, but me ain't feeling he ain't looking too good, nah? No, don't do those things. Don't discuss that. Even if you know the patient, is there's a high possibility the patient might not make it. Remember, we don't diagnose, but based on what you observe, don't let the patient know that. Okay? Do not ask unnecessary questions unless it aids in treatment or satisfies the person's need to talk. Let them ramble. Sometimes while the person continuously talking, it helps to reduce their anxiety. And in between, you train your one or two questions to get information about what happened, what's going on, and so forth. Hmm. Give realistic answers to the person's questions. Try to be positive. Do not make a promise you cannot keep. Okay? Be honest. But don't tell them they're going to die because you do not know if they're going to die. You are not a doctor. We are not going to diagnose. Right. Also, yeah, we will discuss patient confidentiality as we go along. So yeah, thank you for that. Right. Discuss the person's condition calmly and honestly. And again, this is with the rapport with the person. If you have another healthcare professional there, you guys need showing the patient that you're calm as opposed to panicking and having that concerned look on your face goes a long way into making the patient feel comfortable. Allow them to express their feelings. Let them talk. Don't judge them, but let them talk. Okay. Sometimes they may start to cry, sometimes they just laugh at being in this situation. That's normal. Encourage them to express this. And I'll tell you something, a lot of times when they express that and they're done, they feel better. When that anxiety level is elevated, everything goes haywire. And our aim is in attempting to stabilize, we're also attempting to calm down the patient. And that itself helps the patient on the route to recovery and stabilization and recovery, sorry. Okay. Um, Providing competent care. So on the screen here, you see the level of care required of a first aid provider is referred to as the standard of care. What we are required to do. Okay. And when we're looking at standard of care, the easiest way to explain it is if we had two persons do a first aid class and do a first aid course, and they're in two totally different cities, and both of them encounter a patient in a similar condition. Let's say both patients, they were in the kitchen cutting up some food, some vegetables, and they ended up accidentally cutting their hand. The treatment that these two first aiders would administer, even though they're in different locations, would be very similar. It should be very similar. Okay? It should not deviate to anything outside of the norm. And actually, when you look at the curriculum, it would be in line with what you're trained to do. Both persons in similar situations provided similar care. With that in mind, there are boundaries to what you're allowed to practice and do. It is called the scope. There are limitations. The limitations is embedded in the curriculum. That's why we don't teach stitches to EMTs and to first aiders. That's why we don't teach intubation to first aiders and to so on. Well, it depends on what you're doing, where you are, but generally, um, advanced airway and advanced life support is not taught to EMTs. We do basic life support. Okay. So the scope is already bound, but also some organizations where you have EMTs on and paramedics, they have documented medical policies and protocols to define their scope of care. There are limitations. Okay. Always remember, we encourage you to treat the patient to the best of your ability. But understand that in an attempt to provide competent care, we must accept that medicine constantly changes based on research. Okay? And what we may have learned to do 10 years ago may not be what is practiced now. So on screen here, you see some of the outdated procedures. Things like putting butter on a balloon. We've heard there also people talk about using flour, petroleum jelly, or the Vaseline as we know, Vaseline is a brand, right? Or a trade name. But typically we look at petroleum jellies. We don't put these things on balloons. Giving syrup of ipecac for swallowed poison, suctioning for a venomous snake, right? We don't do these things anymore because research has shown it is not beneficial. We have other things we can do that are more beneficial and aid in stabilizing the patient a lot faster and a lot better. Okay? So I'm not going to go through every single one of these here on screen, but the gist of it is that training years ago and not keeping yourself current with the recommended guidelines and measures may result in inaccurate treatment of some of these conditions, or you just may not know how to treat some of these conditions. Okay? Right. Okay, so that's the end of the. Let me just stop the share here. So I will put this on the shell once it's created the classroom. I'll upload the recording as well later in the week. But I'll just pause now and I'll ask you guys if you have any questions.
So I have questions concerning midterm and stuff. What is midterm? When
Right.
is midterm?
I have to work out all those details because with the Tuesday class as well, I was I was very, very ill over the last few weeks. So I just did not have the energy. I didn't even go to work to to crawl out of bed was a challenge. So when I plan to this week come in here, I plan to sit down, look at the timelines and see when we would be mid-semester. Usually the mid-semester exam is just some multiple choice questions, right? I may consider giving you guys some group work as your mid-semester assignment, as opposed to giving the multiple choice. But it wouldn't be anything that is not that we would not have covered. All right, so you just give me a couple days for that. I also, once the e-classroom is created, I will upload the program curriculum. There will be parts of it that are not covered with these PowerPoints. We will discuss some of those additional things as well and cover everything in the program. Okay. Yes, at the end of the semester, there would be a final exam, but the final exam would incorporate both first aid and occupational health and safety. So last semester, I believe it was either 50 or 60 questions, and it comprised of multiple choice and a short answer, and I think some true or false. Okay. And the exam is usually set by both HLED 100 lecturers. Okay, so I would submit some of the questions and the other lecturer would submit some questions and basically just select from both parties. And the exam is online. It would just as all the other exams, it would be set to open at a particular time and close off at a particular time. The mid semester, I don't set it up like that. I basically do it differently, and I'll elaborate as we go along. Okay. All right. So any other questions?
Yes, sir.
Let me just
Do
stop the
we?
recording here. Just hold on a second.
Sure.